We're going to do our next presentation, identifying the appropriate screening and evaluation tools. I'm going to introduce Jodi Allen. She's a clinical specialist, speech and language therapist at the National Hospital for Neurology and Neurosurgery in London in the UK, as well as the National Institute for Health and Care Research Clinical Doctorate Research Fellow at the University College London. We also have Miranda Clements. She's a speech-language pathologist. Her specialty areas include pediatric feeding and swallowing and augmentative and alternative communication in medically complex children. She works in acute care, neuromuscular clinic, aerodigestive clinic, voice and speech clinic, performing endoscopic and videofluoroscopic swallow studies here at Lucille Packard.
I would love to just start our presentation in this area of identifying appropriate screening and evaluation tools by saying I don't think Jodi or I want this to be us talking at you and giving expertise, although we have skills in this area. If you were with us yesterday, you know we talked a lot about the gaps in the information we have available, and I would really love for this to be looked at more as a conversation in terms of what we have available to us right now, what is appropriate for us to use right now, and where we need to go with that in the future.
We're working. Thank you so much. Thank you for having me here in California. I'm delighted to have left the UK. I'm also supposed to be writing my thesis up right now, so this is the perfect distraction. And forgive us last minute presenting, so Miranda and I have been working across time zones to pull this together. I'm really delighted to work alongside a paediatric speech and language therapist to do this. I realised yesterday just how complicated it can be working in the paediatric setting. I receive adults at 16 and I don't really think too much about what's happened before, and it really made me think yesterday that people don't start life at 16. So that was my major take home, I think. So let's kick off. Thank you, Sally, for the introduction. I am based over at the National Hospital for Neurology in London, and I actually am in the really fortuitous position of being able to work wholly with adults with neuromuscular conditions at the moment. We have a neuromuscular complex care unit where our adults come and join us for 2 or 3 days as an elective admission, and they see the whole multidisciplinary team as part of their admission. And that's a really special place to be as a clinician and researcher. Over to you.
And as Sally gave in that wonderful introduction, I am a pediatric speech and language pathologist here at Lucille Packard Children's Hospital. I do work in the neuromuscular multidisciplinary clinic here. I also I'm completely spoiled that I get to work in our other multidisciplinary clinics with our pulmonologists, our ENTs, and our GI doctors as well for our kids with complex aerodigestive disorders. And there's actually a lot of overlap there with our neuromuscular kids as well. So I do spend a lot of my time feeding babies. I spend a lot of my time doing fees and videofluoroscopic swallow studies.
So let's kick off. This is the overview of our kind of next 70 minutes-ish. So we are hoping to talk you through in the next hour or so some of the key components of your assessment and screening tools in bulbar disease, how we might go about selecting them as clinicians and maybe researchers, what types of measurement tools are available to us across adults and paediatrics, what's the patient perspective on these measurement tools, and if we've got time, we've got a couple of case studies to finish off with. So let's start with a little bit of the science behind the measurement tools. You may or may not have heard this term. For me, this was a fairly new term, which refers to the science of how we select and check the quality of our measurement tools. And probably the more familiar term that you may be using is psychometrics. So looking at the validity, the reliability, and the responsiveness as our tools. And I think as a clinician on the front line, that's something we don't always stop and think about. We're in such a rush sometimes to collect our outcomes. We really need to stop and think about what's the science behind our selection of the tool. And so the next few slides are going to refer to some of the work that's been going on in the Netherlands. Hopefully the Cosmin group are familiar to you, but they have been really helpful for me in guiding my selection of measurement tools. So it has a fairly structured approach to both selecting your tools and designing your tools as well. So if you haven't come across that before, please do go ahead and look it up. But on a very, very basic level, what we essentially need in order to measure a bulbar outcome is, firstly, you need to be really clear on what the construct is you want to measure. We've already heard this morning that bulbar function refers to a whole host of things: speech, voice, jaw opening, swallowing. And actually, do we want to measure all of those things at once, or are we being very specific about our intervention and what is it we want to measure? And then we need the instrument. We need to choose the tool that measures the construct that we're referring to, and then we need that process of obtaining the score, and that might be giving a questionnaire to a patient, it might be putting them in a video fluoroscopy suite. Then how do we select the frame rate for the video fluoroscopy? What implications does that have on choosing a different frame rate? So actually it's a lot more complicated than you think on the surface. So a couple of examples of measurement tools. So let's say our construct we want to measure is actually just physically the range of jaw motion, not the functional impact, just how wide does the jaw open. And we might then select, because we're only looking at range of motion, we might just select a measurement ruler. We're looking at millimetres of opening. Great. But then how likely is it that I then go measure it with that tool in the same way as the person that comes in tomorrow to measure the range of jaw opening? So we have to be clear on how we go about using that tool. Another example, I guess, is a very different construct, but still in the bulbar domain, is maybe we want to measure patient experience. Maybe we want to understand how they've experienced their dysphagia. Great, we could just ask the patient, what does it feel like to you in the clinical room? Or maybe we'll use a patient-reported outcome measure, and then you enter that world of, oh heck, how on earth do I pick my outcome measure? And I think on the clinical front line, we tend to just go for the quickest, which is great, but actually, is that time well used if your measurement questions aren't relevant to what you're trying to measure? And what impact does it have if you then give a young man with Duchenne a tool that they're unable to scribe or write on? What impact does it have if we then change that to an electronic form? So those sorts of questions kind of run through my head. Now I've dabbled a little bit in research as well. Final example, very different construct again, but still in the bulbar domain. We're looking very much at pathophysiology now. So we might be really focused on what on earth is going on with the tongue. We hypothesize that we've got weakness and wasting within the tongue. How are our treatments changing that? If we're doing strength training on the tongue, does that change the pathophysiology? So we might be interested in looking at muscle structure within the tongue. Still the bulbar domain, very different to patient symptoms, jaw opening. And we might use an imaging approach. We might use MRI. We might use ultrasound. And then the clinician is there to draw around the region of interest in the tongue and calculate muscle volume and fat fraction. So really different applications within the bulbar remit. And each clinician who probably draws around the tongue there is probably going to draw around it slightly differently. What implications does that have, and do we need protocols to iron that out? Okay, so kind of to start summing up that kind of crash course or the thinking and the science of choosing your measurement tools, it's really helpful to think, I think, as a clinician and researcher, the process of making those measurements, be it assessment, be it screening. So there's a couple of examples on your slide here. So we've got the components down the left-hand side. So thinking about what's your equipment, what prep do we need? How are we going to go collecting that measurement? How are we going to process and store those measurements? One of my biggest bugbears in clinical practice, we use the Sydney Swallow questionnaire a lot. I don't know if you're familiar with it. I think it's a great tool, but I have to carry a plastic ruler around everywhere I go. So if I haven't got my ruler, I can't score it up on the move. And then, you know, you're cursing because you've lost your ruler. And then you have to assign your score. And then what on earth does that score mean? What do the studies tell you about that score? And actually, what happens if they then score 10 points different next year? What relevance does that have? Does it even mean anything? So there's an example there for patient-reported outcome measures, but also our gold standard assessment. So X-ray video fluoroscopy is often referred to as our gold standard assessment. And yet there are still huge inherent problems with our X-rays. We might use different settings, we might use different frame rates, and we might measure it really differently. So we'll kind of talk through those issues as we go through. Okay, so for us, the selection of your assessment or your screening tool for bulbar function very much depends on what you want to measure. And I think that's really important to hold in your mind all the way through. Why you want to measure it, what's the context in which you're measuring it? Is it clinical? Is it research? Is it both? How do we merge the two? What are the kind of measurement properties of that tool? Is that tool good enough to use for the purpose you want to use it? And actually, and really importantly, Miranda kept reminding me of this, is what's the interpretation of that tool? How feasible is it to deliver in a busy clinic? And how do we interpret that score? So question 1, what do we want to measure? So depending on which paper you read, which clinician you talk to, will all define bulbar function very differently. We might define it very broadly, or we might define it really, really specifically as per its traditional use. So bulbar function, as you all know, used to refer to does refer to the bulb, the medulla in the brainstem, and all of the lower cranial nerves that affect or come out of that bulb, the brainstem. But actually, we're using it much more broadly in neuromuscular disease, aren't we? We're not always looking at cranial nerve function. We're looking at muscle, intermuscle, and nerve function, but also primary muscle issues. So I think it's really important to make sure you're clear on what you're trying to measure here. It might be very isolated to voice. It might be related to speech. It might be related to really specific measurements of the swallowing. It might just be looking at tongue-based movement within the swallow. It might be looking at the entire swallowing system. So being clear on what your bulbar function is really important, what aspect. And then once you've kind of defined what you're looking at, it's helpful then to define that a little bit more. So for example, maybe we say we're going to look at dysphagia, we're going to look at swallowing function. Now, I often think about using the ICF framework to then drill down a little bit more to understand what aspect or what level of dysphagia are we going to look at. Are we really looking at the nitty-gritty of the function, the pathophysiology? Are we looking at muscles? Are we looking at imaging the tongue? Are we looking at imaging the level of the muscle cells? Or are we really more interested in the functional components of dysphagia? So the relevance to day-to-day life. What are the symptoms of dysphagia? Maybe we're more interested in the participation aspects. So what impact does the dysphagia have on someone accessing a mealtime, going out and joining friends for dinner, etc., etc. So I think having those clear in your mind can be really helpful. I think what we tend to do in speech therapy is we often end up measuring the consequences of dysphagia. A lot of our screening tools measure aspiration, not dysphagia. And having that really clear in your mind is helpful because you're not screening for dysphagia, you're screening for aspiration, a consequence of dysphagia. Is there anything else you want to add there? No. Just yabbering on.
No, you're doing great.
Okay, so once we've thought about what we want to measure, we want to be really clear on why do we want to measure it. So we've been tasked today to talk about the difference between a screening and an assessment tool. And again, it's really helpful for me. I always come back to, hang on a minute, am I screening here or are we assessing? And I think the difference here that you probably already know, but again, this acts as a reminder. We're looking for a yes-no response of our tool, really, aren't we? Yes, we think there's a risk here of aspiration. Yes, they need an onward referral to a specialist. So essentially, our screening tools evaluate the possible presence of a particular problem. It determines the need for a further assessment. They tend to have a binary outcome, and they tend to be used by the whole MDT. not just a speech and language therapist. They tend to be, by their very nature, straightforward and accessible and low cost. And then on the flip side, your assessment will follow potentially your screening. So your assessment is far more comprehensive. It gets into the nitty-gritty of defining the nature of the problem. So we might screen for aspiration, but then we might start assessing the dysphagia, for example. Your outcome of your assessment, you hopefully will then come out with a diagnosis, and that assessment process might take 20 minutes, it might take 3 days, for example. And from that assessment, we design our treatment. We really focus in on what are we trying to work on here and what are we going to do as a therapist or indeed a researcher.
And I think, sorry, I didn't mean to interrupt you. This is the question that I brought up earlier and that came up a lot yesterday. And I think it really gets at an important piece of what we're trying to do here today in our discussions in general, because we know in this era of disease modifying treatments for neuromuscular diseases, we don't have normative data. We don't have long-term outcomes. We have a need for research and more information. And we also have a need to care for our patients. And those don't always mean the same thing when it comes to choosing your assessment. So really the why am I doing this? And what is the setting that I'm doing it in? Am I screening someone quickly in clinic because I need to send them to the appropriate providers for follow-up care and to make a treatment plan for them? Or am I collecting data because I'm thinking about the long-term outcomes for this population? And both of those are things that are extremely needed right now, but we may not be able to get at them with the same assessment tools. So something I think we should all have in our minds as we discuss today.
Yeah, I totally agree. And it would be a perfect world, wouldn't it, to be able to use the tools for research and clinical work combined. Okay, so I think we've covered this already. So we've talked about the purpose of the measurement tool, what the level of measurement is that you want, how the tool then responds to changes in measurement, and then what are we going to do? How rigorous are those scores and how meaningful are they to the patients? So again, I'm just going to touch on this because I'm sure it's in everyone's mind, but sometimes we need to just bring it back to the forefront about what are the properties of our measurement tools. And this, this infographic has been designed by the Cosmin Group in the Netherlands, and it really quite nicely highlights the aspects that we should be thinking about when we pick our assessment and screening tools. So we're looking at whether the tool is valid. One of the challenges in rare disease is that it might have been validated in a different population. Can we then use it in our population, or do we then need to validate it in our own patient group? Is that tool reliable? So if Miranda and I go and conduct exactly the same assessment, how likely is it that we're going to come out with the same outcome? Or if Miranda went back 2 days in a row, will she still have the same outcomes? But importantly, and I think this is one that I always come back to, is responsiveness. So for me as a clinician, but also a researcher, because we're looking at the impact of interventions, is, okay, we're not really interested just cross-sectionally about our patient. It's helpful to have their current picture, but most of the time as clinicians, we're interested in how things are changing. Are they progressing? Is our intervention actually improving things? Is that drug therapy working? And actually responsiveness is something certainly in our speech therapy toolkit that isn't very well studied in our existing patient-reported outcome measures. And that's a real sticking point, I think, because we don't just want to measure this patient once, we want to measure them multiple times. Okay, and just a refresher again on validity and reliability. This again has come from the Cosmin Group. What we're looking for is a tool to measure what we want to measure and measure it in the same way every time. Okay, we're trying to avoid these aspects where actually we're measuring something completely different, but we're doing it in the same way. I mean, that's good news to some extent, isn't it? But we're still not measuring what we want to measure. Well, we really want to avoid a tool that's not measuring what we want to measure and we equally come out with a different outcome every time. So we're trying to aim for something that measures what we want to measure and we measure, it comes out, the outcome is the same every time. Okay. And really importantly for all frontline clinicians is how practical is the measurement? We might say today, hey guys, we found this really cool tool. It takes 45 hours to do it, and the patient has to travel across America to get to the tool. So actually most of the relevance here is how practical is it to do this or singing and dancing assessment? But also how easy is it to assign any meaning to it? Great, we've got some I can see some beautiful visual, fat infiltration on this MRI, isn't that wonderful? What relevance does that have? Okay, so all of these things will depend on the context, whether you're using it in clinical practice or research, ideally both. But balancing, I think, the psychometric or the clinometric properties of the tool is really important to balance with practicalities. How easy is it to use and what outcome are we going to get from them? Okay, and I've just popped this slide in for those who are not so familiar with Cosmin. It's a really, really useful website on helping you select the right assessment and measurement tools, kind of a checklist to go through. Okay, so when we were given the title of this talk, both Miranda and I said, wouldn't it be great if someone has just done a systematic review on this for us? Because then we can just present the findings of the review. And it's not, it won't be a surprise that, yes, of course, there have been systematic reviews on patient-reported outcome measures in swallowing, patient-reported outcome measures in neuromuscular diseases. If you look at the dates on these, we're kind of going back 10-ish years for most of them, with a slightly more recent one here, well, very much more recent actually, last year from the Netherlands again, on patient-reported outcome measures in neuromuscular diseases, and that's all encompassing. So as you can imagine, the outcome of that review was, there were very few swallowing-related outcome measures embedded in that review. And for any of you who've read systematic reviews, hopefully that they're going to, at the end they'll go, use this tool, this is wonderful. Of course, that doesn't happen. And depending on how they critique the tool within the systematic review, some tools come out better than others. But we'll talk you through some of those outcomes as well. Okay. So these are the tools we're going to talk you through, the assessment tools. So we're looking at patient-reported outcomes, observer-reported outcome measures, clinician-reported outcome measures, which includes imaging, and then any performance-related outcome measures, which are outcome measures based on asking your patient to do a task. So the physio equivalent, I think, is something like the 10-metre walk test. What are the equivalents in bulbar function? And I think it's fair to say the focus here is very much on dysphagia because that's really where we sit. So we kind of make no apologies for that. But I think Miranda's already said we're inviting audience participation for, all other aspects of bulbar function. So.
Yeah, this is a very swallowing heavy presentation, and we recognize that. So not to take away from the speech aspects. And also, it's not an exhaustive list of what is available. We really wanted to talk about the type of tools that are available and give some examples. So there are certainly things that we're not going to discuss that might be a very appropriate tool to use.
Totally. So we're going to start off, this is really familiar scene in my clinic, and a lot of our neurologists would say that actually, yeah, this is really, really common. So on a very, very basic level, this is a patient-reported outcome measure, isn't it? Your patient walks into clinic. So a lot of my work at the moment is in myotonic dystrophy. And within that disease, of course, we know there are, that you get anosognosia as part of the presentation, so indifference to lack of care for their own condition, but also apathy, disease apathy. So a number of our patients with myotonic dystrophy will be asked by the neurologist as our basic screen as to whether they need speech therapy. Any problems with swallowing? Nope. And then we move on to the next question. And I think it's fair to say a lot of our patients don't really know what problems with swallowing are. So you could argue that question is not particularly sensitive to picking up the problems. But even if it was, how likely is it that the patient's going to report them? But interestingly, maybe later in the consultation, they will say, oh, doctor, can you help me with this cough? I'm always coughing after drink my tea. But that doesn't connect with problems swallowing. So what is available in terms of a patient-reported outcome tool for adults? And I know Miranda's then going to talk about paediatrics. So this is a tool that I certainly use in clinical practice. We use it with all of our patients who come through our neuromuscular centre. It's a 17-point scale, and it's a visual analogue scale, which of course has issues in itself. The reason we've picked this as a tool to use clinically is because actually, unlike a number of the tools that are out there, there has been some use in neuromuscular conditions. So there's 3 papers there where actually it has been used. And whilst it's not been psychometrically tested in adults with neuromuscular disease, I think it gives us a little bit of information as to what the tool can offer. So very early on, the tool was designed or validated in a huge cohort of patients, which included neuromuscular conditions, but a small component of them. But it has been used in patients with oculopharyngeal muscular dystrophy, albeit a small number, a number of years ago. But they use this tool as an assessment tool to evaluate the impact of upper esophageal sphincter dilatation. And they found that the tool showed they were able to demonstrate improvement. Of course, we don't really know how clinically meaningful that improvement was. It was statistically significant. And of course, statistical significance doesn't mean clinical significance, but it was sensitive to change to some extent as an outcome measure. It's also been used in a cohort, again, a small number of patients with Duchenne muscular dystrophy, by a colleague of mine, Sally Archer, as a tool to detect dysphagia in this group. So she compared using the patient-reported outcome measure with a clinical assessment of dysphagia and established a cut-off score for patients that did or didn't have dysphagia. Again, there are problems with that. There wasn't a gold standard assessment for dysphagia, if there is such a thing. But it also shows that it's got potential as a screening tool to rule in, rule out dysphagia. And again, a more recent study, a big cohort of mixed adult with neuromuscular disease, which of course is quite exciting to see that number in a paper, used the Sydney Swallow score again and showed that actually the tool, the Sydney Swallow tool, was yielded or found or established dysphagia symptoms in a much higher group than those that actually reported it in their consultation. So a little bit more sensitive to the symptoms. Does anyone else use this tool out of interest?
I do.
Just you. The other one that's really familiar to a lot of speech and language therapists is the SwalQual. This one really often, in all the systematic reviews, comes out really well psychometrically or clinometrically. And so this one is used quite a lot in research studies. Clinically, though, its big critique is that it's long. I think it's something like 47 questions. And actually, I've used it as a tool as part of my PhD. And I asked the patients, they do a whole gambit of tools, as about 5 hours worth of testing. And I asked them to write about their experiences of the tool at the end of the study. And there's always feedback on this one. The questions are confusing. I didn't know what you meant by this. So actually, the patient experience in a myotonic dystrophy population, I think they found it quite difficult, actually. However, they didn't mind spending the time filling it in, surprisingly. I thought it would be too long for them to complete. But it has been used again, small cohorts of patients with oculopharyngeal muscular dystrophy and patients with myotonic dystrophy. And actually what they found in both of these applications is that there was a ceiling effect when it's used in this patient group, particularly with the myotonic dystrophy group. Again, I'm going to let you speak to the second one because I'm less familiar, but there is another tool I'm just going to highlight to you. It's called the dysphagia meter. This is our colleagues over in Canada who've developed this in OPMD, and I think it's still undergoing validation, but it's a very patient, group-specific evaluation tool for OPMD. And I think that's really neat, although I guess the question for me is always, can we afford the time to develop specific dysphagia assessment tools for every single neuromuscular disease? And actually, should we trying to be grouping these phenotypes together so we're not investing lots and lots of time for patients for very individual disease groups?
And the neuromuscular disease swallowing scale is very similar to the functional oral intake scale in that it is like, I think it's a 6 or 7 point rating that goes from like I'm full oral feeding, no restrictions, down to I'm enteral fed and take nothing by mouth. I believe there's some different points in there related to residue, but don't quote me on that. But it's a very brief, like a scale. I'm either on this level or I'm not, and there's not a lot of nuance to it.
Yeah, I think my understanding it's a little bit like the voice for those that have used it. But we've never used it in our practice, I say.
It's very helpful for establishing a baseline and watching change over larger periods of time, but it's not really going to give you any good information between like a few months for any given patient. Yeah.
Over to you.
Oh, okay. And then patient-reported outcomes in pediatrics. I know Jodi mentioned earlier, you know, in the world of peds versus adults, we have confounding variables in that development is a factor, and concomitant developmental delays that might occur are a factor, and patients can't speak for themselves till they get older. So it does make this sort of outcome a little bit more challenging, but there are problems that can be used in pediatrics. I know the screening list physician piece of the neuromuscular disease screening list has questions like this that are directed at the caregiver, again, to get at pieces of dysphagia that might be missed or just to prompt an assessment. So this one is just like a yes-no scale, and you get a score at the end, basically saying, do you need an assessment or not? And then we just mentioned the FOIS, the functional oral intake scale, which is a very brief level 1 through 7. This child takes a total oral diet with no restrictions or nothing by mouth. This is nice because it can be scored by pretty much anyone who can ask about feeding. For the patient, the family generally has a good idea of how they're feeding their child, but it's not giving you a lot of specific information, which can really make a big difference in a treatment plan. So again, going back to why are we asking? Why are we gathering the data? How is it relevant? And then another one that I sometimes use is the EAT-10. Again, this is a 4-point rating scale with different questions related to swallowing. And I actually like this one a lot for the neuromuscular population because it does ask things like, does eating take extra effort? Swallowing is painful. Some of those things that are a little bit more problems that we might not hear from the family when we ask, hey, do you have any problems with eating? And they say, nope. But if we give them a questionnaire like this, and they're actually prompted by these questions to be, actually, yeah, it takes me an hour to feed my toddler. And that's me trying to feed him the whole time, not because he's running around, things like that. And it can be really helpful to guide treatment.
Yeah, and I think this is the one that I see an awful lot more in the research studies. The EAT-10 does get pulled out. However, when you go to any of the dysphagia conferences, the EAT-10 gets a lot of flack. And I think it's used predominantly because it's nice and short. It has been used, I know Emily Plowman, who's a speech therapist over in the States, she has used it as a tool, tried to engage, actually assessed its sensitivity to detect aspiration in the ALS group. So it's worth looking up that paper if you're interested in a screening tool binary, yes, no for ALS. But I think, one of the bigger challenges with the EAT, as with a lot of our EAT-10 outcome measures, is its responsivity to change over time. So
I think that's the overarching difficulty that I have as a clinician with these tools is like the sensitivity. Is it getting at what is going to help me make a difference between clinic visits. Like they're all going to track some sort of change over time, maybe, and they might be really useful for collecting long-term data points, but not a lot of these existing tools are clinically significant to me when I am seeing a patient and trying to help them with their feeding plan. And I know if you joined us yesterday, like there is work underway to fix that specific for the neuromuscular population, especially in this changing era that we're in. But, you know, we are working with what we have. And I am very much a clinician. I'm not a researcher. I'm passionate about research. I want it to happen, love it. But I have a clinician hat on when I look at these things. So like I took this presentation and talking about these tools very much from a what is functional for my patients, because that's my role. But I recognize that that's not the only thing we're doing here. Okay. So the benefits and functional considerations for the problems, I feel like I just talked about some of this already. They're really nice because they're cost effective. It's a piece of paper you can use in your clinic. It's quick and easy as a screening tool. It doesn't require a clinician to fill it or to administer it. It's helpful for tracking the change over time if the responsiveness is proven. And again, for our patient population with neuromuscular diseases, that's where we're finding challenge with these types of tools. It does provide some form of quantification where standardized assessments are not available, which is really, really helpful. Of course, even as a clinician, I'm wanting to collect objective data as much as I can so that I can track progress over time and be specific and you know, not feel like I'm being, what is the word I'm looking for? Like objective data in treatment is equally as important as it is in research. And so that is important even if you have your clinician hat on. I think we all know that.
I tried to help you out there, but
Blake,
I can't find the word for you.
It's because you told me that I was good at improvising. And so I was like, no, I'm not. And then the functional considerations are, of course, the informal use is high, but validity reliability is poor for a lot of these. The need for refined questioning in this population is very high. Like we need questions that are specific to bulbar dysfunction, that is specific to people with neuromuscular diseases, especially when they're progressive, especially when they're the change over time. And in pediatrics, that doesn't look like decline over time necessarily, even for a child with a progressive neuromuscular disease. Like they have maybe severe hypotonia at birth and they're gonna make developmental gains before they start declining eventually. And like, how do we track that over time in a meaningful way? It doesn't necessarily correlate with other aspects of the disease. And then of course, we want to consider the ability of the patient or the caregiver to complete. We had a lot of discussion at my table yesterday about, you know, the readability of some of these assessments and what is culturally and linguistically appropriate, and does it even make sense for the way that they feed their child or their adult at home. And then so that reliance on a parent or caregiver to quantify symptoms is also challenging, because for pediatrics who can't speak for themselves, or even an older adult who can't speak to their own symptoms, we're relying on somebody else to quantify that for them, which is hard. All you.
Me?
Yep.
Okay. Hit me up. So this one actually is less familiar to me. So observer-reported outcome measures, and I think, you know, ultimately Miranda's going to have more to say on this because I think it's probably more relevant to pediatrics. Mm-hmm. Essentially, we're putting a third person into the mix, aren't you? And again, I'm imagining myself sat in a myotonic dystrophy clinic, and I know the neurologist who refers to us, he always looks to the caregiver when the patient says no. And actually, the caregiver, more often than not, will have something to say. And you know, for the reasons for that we have to unpick, but actually there really often are caregivers, even in adult care, can add really valuable information, because they will say, do you remember, George? You choked on that chicken last week, or, oh yeah, do you remember we called a paramedic? Oh yes, we did, yes. Mm-hmm. You know, that's the level of reporting that sometimes we struggle with. Mm-hmm. And the voice, again, is really interesting, isn't it, in some of our adult patient groups. And for me, I find it fascinating to compare maybe our Duchenne boys versus our adults with myotonic dystrophy. We know that our adults with myotonic dystrophy will not change, often don't change the way they eat at all. So on a foist, they will be maximum, eating everything. Whereas our young men with Duchenne will often modify naturally as part of their disease. So as a clinician, you have less work to do potentially.
But on the other end of that, when our patients are super savvy about their own deficits and they have good self-monitoring skills and they make those modifications over time, their answer to this question is going to be nope, because I don't have problems swallowing because I fixed them on my own, and I know we talked about that yesterday too. Like, is my answer to you that no, I don't have problems eating and swallowing, is that because I only eat purees? Is that because I chop my food up? And a lot of times patients do this without even realizing they're doing it. And then when you ask them for a diet recall and they tell you what they're eating, seasoned clinicians, we can see, oh yeah, there's a pattern here. You avoid hard to chew foods, or you avoid things that are mixed textures and have liquid component. And the patient has no idea they're doing that. Just over time, they learned, oh, that was hard for me. And so I stopped eating it. And so that can confound this as well.
Absolutely. I find it intriguing as to what is underlying all of those, the reasons for poor patient reporting as well. And I think regardless of in addition to all of those factors, I do think our patients with chronic dysphagia have visceral changes within the pharynx. They desensitize. So actually, maybe they truly aren't recognizing that food is stuck in those. It's a complicated one, isn't it? So yes, this is an example that is so far away from neuromuscular, but it's a neat example of a carer reported out or caregiver reported outcome measure. So essentially they may or may not be including the patient in part of the assessment, which I'm sure they would be, but they've also got an additional tool, which is the caregiver reporting. And I think that's really neat and actually potentially quite applicable in our patient group as well. And I think there's a way to go for this, and actually a nice overlap here between paediatrics and adults, because often, as per the discussions yesterday, you're switching from a caregiver report to a patient reported outcome measure. And actually is the potential here that you can move with a caregiver reported outcome measure all the way through the years. This again is I say there wasn't anything relevant, but actually this is a really neat caregiver reported outcome measure. It's caregiver quality of life specifically focused on dysphagia. So I was really excited when this came out a couple of years ago, led by a speech therapist, Samantha Shoon. So she has developed a scale for caregivers that is designed to look at the impact on the caregiver's quality of life directly related to dysphagia. And that for me was mind-blowing because actually I'm not sure sometimes you can really tease out quality of life related dysphagia when you're working with a group of patients who have so many other problems as well. I've included this tool as part of my PhD as well. So I'm going to hopefully look at the relationship between the caregiver quality of life and the actual dysphagia and the patient reported, to try and answer some of those questions as to whether it truly teases out quality of life related or dysphagia related quality of life in caregivers. And there's just a couple of questions or example questions that are in the tool. So one example is, because of my loved one's swallowing problems, extra time is required for meals. So from their perspective.
And, we included some of these in the proms earlier, but for pediatrics who are not yet verbal or unable to report for themselves, a lot of these outcome measures that we're using become inherently observer reported because we're relying on the caregiver. I mentioned that already. There are scales such as the PEDI-EAT available. They may not capture the nuances of swallowing problems specific to neuromuscular disease. I feel like I've said that 10 times, but I guess that's my takeaway is like we need specific scales for this population, but these are helpful for more specific pediatric questions. And they ask things like, my child drools when eating or insists on being fed by the same person. So there are some little things that are specific to infants that we may not see with teenagers and adults, such as like, oh yeah, they eat fine, but I have to go in a dark room and I have to hold them in this position and I'm the only one who's allowed to feed them. And those are red flags for dysphagia for that child, even though the family may not see it that way. They may see it like, my child is selective about how they eat. So having tools that can help get at those things so that we can help is important. Okay, so there is a paucity of tools available to assess bulbar function in pediatric. Of course, efforts are underway. We still need more research. We had a wonderful conversation about the development of the IBAT tool, which I'm super excited about, that came out of those working groups. And I know there's many people in this room who have put so much work into that, and I'm super excited about it. I'm not going to go into this too much because there was a lot of discussion about it and people in here who will speak much more to it than I can. But I just wanted to point out, like, you know, we are doing the work. We need to keep doing the work. But again, a lot of the conversation around this is why are we using the tool? What is it for? Is it going to capture what we need it to capture? Okay, so for observer-reported outcomes, summary, what construct are the observers measuring? How does it associate with the patient-reported outcomes? Can we trust their observation? Is what they are answering relevant to what's happening at home? And then is there an opportunity for standardized outcomes across pediatric and adult when it's observer-reported? I don't have an answer to that. I don't think you do. Does anybody here? I would love to say yes for sure. But these are, again, they're tools that are useful to us in some way and definitely have their drawbacks. Okay, so for clinician-reported outcome measures, these include our clinical global assessments. They can be a plus-minus rating scale. We have severity categories within the assessment. Instrumentation falls into this group, and as we've discussed several times, like the video fluoroscopic swallow study is the gold standard for assessing dysphagia. We also have MRIs, ultrasound, functional endoscopic evaluation of swallowing. Cervical auscultation has been mentioned. I'm going to touch briefly on the pharyngeal manometry, which Caitlin McGrattan discussed yesterday as well, which is newer and exciting and another way that we can provide objective data to our swallowing assessments. And then for screening, for pediatric screening on a global assessment, again, swallowing, this would be a patient caregiver interview. We're doing an oral mech or a cranial nerve exam. We're doing a feeding observation. We might do something like the 3-ounce water test if it's appropriate. Again, where the clinician is collecting the data and they are using it to either screen or make an assessment. And then for speech, this might be the only place where I really talk about speech. I apologize. It's similar. We're getting a parent caregiver interview or a patient interview if it's an adult. We're performing that oral mechanism exam, a cranial nerve exam. We're getting a speech sample. We're assessing their alternating and sequential speaking rates. We might assess their voice with something like an S to Z ratio. I recognize there's a lot of speech pathologists in the room and a lot of people who may look at that list and say, what does that even mean? But essentially, it's the features we're looking at. Can you be understood? Is your voice dysphonic, or is your respiratory support insufficient for speaking? Can you speak for longer times? What are the features of dysarthria that we need to classify and then treat? And that is, again, particularly difficult in pediatrics because we have the confounding variables of developmental progression. You know, is this a speech sound that is a phonological process that's appropriate at the age of this child, or is it a dysarthric feature? And we don't have a lot of great objective assessments for diagnosing pediatric dysarthria differentially from developmental disorders, and that's another area of need. But you know, we do rely on those assessments, and we need to consider what is the cultural background and the linguistic background of the patient. Is the assessment appropriate from that standpoint? Do they have the cognitive ability to participate in the assessment? And then, of course, standardized assessments that get at speech and language. Patients with neuromuscular diseases are not captured in their normative sample. So how is that affecting the scores that we're getting? And then what features are we assessing? Is it looking at articulation? Is it looking at resonance? Are we getting good information about voice? Will this child participate in a voice evaluation, or am I just going to have to do what I can watching them yell as they run around the treatment room? And then their respiration. And then for swallowing, you know, we're looking at chewing. We know that for neuromuscular diseases, there are, you know, oral phase dysphasias with the efficiency and the chewing. There's pharyngeal phase dysphagia with the ability to swallow and clearing residue and pharyngeal propulsion. And then they often have esophageal components of dysphagia too that may need to be addressed. And how are we assessing that with things like measuring the mandible opening and bite measurements and instrumental evaluations? And how are we using that information to make change? So for a clinical feeding, I'm going to just go over what these clinician-collected data might look like. A clinical feeding assessment, sometimes referred to as a bedside feeding evaluation. This is what goes into that. This does require a feeding specialist to perform a comprehensive case review, the oral mech exam where we're looking at their oral facial tone, their cranial nerve exam, their oral facial structures, their strength and range of motion, and then assessment of their dentition is a part of that. Of course, we're going to watch them eat. For this piece of the assessment, it's not just, watching the food go in the mouth. It's what's their physiologic state, their developmental status, their positioning, their overall appropriateness to feed. And then feeding behaviors of both the patient and the person who's feeding them, and how can we help there. And then evaluation of the oral phase of the swallow can happen in a clinical feeding assessment. You cannot assess the pharyngeal phase of the swallow in a clinical feeding assessment. I think most of us know that. But their oral containment, their chewing pattern, their safety with different textures, consistencies, bolus preparation, posterior transit of the bolus. Are there changes over time with fatigue? How long is it taking them to finish their meals? And then, of course, we're observing for those overt signs and symptoms of aspiration. And again, we're screening for aspiration, not dysphagia in that moment when we're looking at those things. Of course, the limitations, we cannot detect aspiration on a clinical feeding assessment. There's no evaluation of the pharyngeal phase of the swallow, but it is an important first step a lot of times in getting those assessments. And I thought of this earlier when somebody asked the question to Sarah of, if I see a patient who has chewing difficulties related to weakness, where do I refer them? And my first thought was, how do you know the chewing difficulties are related to the weakness? Because we haven't had an assessment yet. There might be something else going on, and there often is. So my answer to that question is yes, I think they should see a neurologist if there's an undiagnosed impairment, but it's not too early to send them for a feeding evaluation because that's a first step in getting them help.
So I think we follow a very similar route with a clinical evaluation in adults. One of the challenges for me working in a centre where we see the same patients year in, year out, is that it's almost criminal not to collect measurements that will contribute to understanding the natural history of bulbar function in neuromuscular disease. And I think the Netherlands team, and I know Maurice is here, they set the standard there because they collect quantifiable, repeatable assessments in their patient group year in, year out, and we can get really valuable information in doing that way. So we've tried to follow suit. I won't claim that that was my idea. So thank you to the Netherlands team for really, setting the mark there, the benchmark to meet. So, but the challenge with the clinical exam is, of course, we all do it slightly differently. And we know that the clinical evaluation, depending on the experience of the clinician, you will probably yield a different outcome from the clinical exam. And that's a real challenge. So it's not particularly quantifiable. The outcomes are dependent on the clinician that goes in. If it's a specialist in neuromuscular, you'll probably find that quite a different outcome to somebody who maybe specialises in stroke. But that's the world we live in. Speech therapists work across lots of different domains. So in lots of ways, we try and add in tests that try and quantify it a little bit so that if a different clinician goes in the year later, we've got some sort of idea of whether things have changed or not. So what we've done in our centre is try to standardise our clinical assessment. So we've basically created, glorified drop-downs. So when we do our bulbar function examination and we look at brow furrow, we don't say moderate brow furrow. We've tried to quantify it and standardise it within our own speech therapy group so that each time that patient comes back, we know that mild is mild and moderate is moderate, and we know what mild and moderate means between our group of clinicians. So it's not being validated, but we're finding it much more useful to quantify change by standardising the assessment for neuromuscular.
I want to add too that our institution on our feeding team with speech pathologists and occupational therapists do something similar in that we recognize the downfalls of having the variability in clinician assessment and how inherently subjective that is. And so one of the ways that we try to combat that in our institution is meeting regularly about it, using similar scales that we've developed together where we all have an understood definition of what we're looking at between our group so that we can at least help mitigate that a little bit. But of course, this is something that we are spoiled by because we are working in a medicalized environment with a team of other experts with us. And that's not something that someone working in a private clinic or doing home health out in some rural area is going to be able to do. So it's nice that we have the opportunity, but it doesn't help those providers.
Although having said that, we do try and train our community colleagues in the same tool so that actually our community teams are still doing the same thing as us.
Really great. Yeah.
We try.
Yeah.
So that's just an example of a tool that we're really happy to share if people work in this area and want something that's been designed without reinventing the wheel. I'm going to let you talk about these.
Okay, and so then, of course, we've mentioned several times the instrumental assessments are the gold standard for assessing pharyngeal phase dysphagia. The video fluoroscopic swallow study is the best tool we have. There definitely are some standardized tools like the, what is it called? The MBS-IMP, thank you, that helps clinicians be a little bit more objective in their rating. There's a penetration aspiration scale. Actually, the pediatric version of the MBS-IMP came out like a week ago, which I'm super excited about. I've been waiting for that. And these are the best we have in terms of objective instrumentation, but there are downfalls to it. It is still just a brief moment in time for this child. It requires radiation. We can't watch a whole feed. There are variabilities in the way that different clinicians and different institutions report the outcomes. But it's a very important tool that we use to guide our practice with bulbar function because it's the only ways we have to look at pharyngeal dysphagia. So just a brief overview of what a video fluoroscopic swallow study is. If you have never seen one or performed one, it's a dynamic x-ray of the oral pharyngeal swallow function. Sometimes we get a little bit of the esophageal piece too, but that's not what we're looking at. Here at our institution at Lucille Packard, they're completed by both speech pathologists and occupational therapists. I know that's not true in other parts of the world, but in the United States, there are several pediatric centers that definitely do that. They are able to assess before, during, and after the swallow. They can assess virtually any consistency, which is really nice. You have to give the child barium, of course, but you can mix barium into pretty much anything. And then we can definitively identify laryngeal penetration or aspiration, but again, there's variability there, even as you mentioned, like how many frames per second are we pulsing? Because the gold standard is 30 frames per second, but I know there are institutions that pulse at 7.5 for a video, and are they missing aspiration because of that? And then, of course, the exam's time limiting because of the ionizing radiation. Patient has to consume barium, especially in pediatrics. That can be challenging. 2-year-olds really don't like barium. They really don't.
20-year-olds and 40-year-olds don't.
But you can reason them through it. 2-year-olds can't be reasoned with. I don't know if you know them, but there's no getting that barium in their mouth if they don't want it there. And of course, we're not going to force it because we want a good assessment of their natural swallow, and this is already a highly medicalized environment, right? And so I'm not going to syringe a child with barium to get an assessment of their pharyngeal swallow when they were force-fed, because if they aspirate, that's not fair, you know? So you're dependent on their participation. For any age, really, positioning is challenging, especially for neuromuscular patients. Getting into the fluoro suite and into the fluoro chair can be a huge challenge. I know here that has been a barrier sometimes to getting a video fluoroscopic swallow study in some of our older patients who are wheelchair bound. We have to schedule it around the IR schedule so that we can use the C-arm machine and keep them in their same chair, and that can cause delays in even getting them the study in the first place. And also, what? Oh, yeah. So of course, you know, there's benefits and limitations, but it is the best we have right now. You can move forward. And then there's the functional endoscopic evaluation of swallowing, which is another valid tool for assessing pharyngeal dysphagia. It's typically completed by a speech pathologist and an ear, nose, and throat doctor. Sometimes SLPs complete it independently. I think this is more common with adults. I think most pediatric centers have the ENT passing the scope a lot of the time just because of the nuance there. Of course, we can again assess virtually any consistency, including breastfeeding, which has been an invaluable tool for our babies with SMA who are treated, and we're getting that initial assessment and they're doing really well with breastfeeding, but maybe they have some symptoms of dysphagia that we want to assess. We have a way to do that. It does provide a dynamic view of the laryngeal anatomy and function, which is really helpful, especially for things like secretion management. And, of course, looking at their tone in their airway is helpful from that view. But specifically for neuromuscular disease, I know sometimes it's really helpful to have a FEES. Even if the video showed maybe some post-swallow residue, we get a FEES and see, actually, that's a ton of secretions hanging out in their hypopharynx. And if we use some strategies to swallow those down first, they look much safer with whatever consistency we're trying to give. So I find that to be really, really important. But then again, it's similar to the video in that there is variability in clinician interpretation of this test. And there are some objective measures for FEES in adults, but there really aren't any for pediatrics, and there's room for growth there for sure. It's nice because no radiation is required. It's nice because the patient can stay in their home chair. We can be a lot more flexible with positioning because we don't have to have the fluoroscopy machine in the right position to get the view we need. We can work around the patient much more. There are FEES clinics that are mobile that can go to people's houses when they can't come to the clinic, which is really nice. We can assess a longer feed. It's not limited by radiation. Of course, limitations for pediatrics, again, 2-year-olds don't like having a scope in their nose. I don't think 20-year-olds do either. Babies definitely don't, but they usually get through it okay. I have actually found that we generally have good participation for pediatric FEES when we're prepped for them appropriately, but it's not fun. And then you have to question, like, how are they feeding with the scope in their nose? So there's discomfort related to that. And then we are not able to view that exact moment of the swallow because of the whiteout period. Anything to add to that?
Not huge amounts to add to that from an adult perspective. Personally, we tend to favour video fluoroscopy in our adult group, largely because it will give you a biomechanical assessment of what's moving and what isn't moving, whereas FEES will largely give you a symptom report on what's stuck and where is it stuck. And actually, in a lot of our patients, where all of our neuromuscular patients, where the problem is food stasis in the pharynx, you give them one mouthful and you can't see anything with your scope, unless you're a really skilled endoscopist. So we tend to favour video fluoroscopy, but actually you make a good point about people not liking barium. So I had 94 patients with myotonic dystrophy had a video fluoroscopy as part of my study, and I showed one of the anonymised videos to my colleagues and said, "What do you think about this person's video fluoroscopy?" And she said, "Gosh, they're really dysphagic, aren't they?" And I said, "No, they just didn't like the barium." And actually, it was incredible to see because we don't, in the clinical world, we don't video fluoroscopy people with theoretically normal swallows. And in this study, people had theoretically normal swallows to some extent, and they really didn't like the barium. And the way that manifested on video fluoroscopy really surprised me.
Interesting. Yeah, we tend to look at FEES and VFSS as complementary studies a lot of the times, depending on where they're at in their treatment care. And then again, decision-making into why we're getting the exam is going to inform my decision on which one I'm picking. For example, if I expect someone's in an acute, say we're assessing their swallow during an acute illness and I expect them to get better and improve with their recovery from their illness, I'm not necessarily going to go right to the video because I want to avoid the radiation if I think we're going to need that later. And so I may preliminarily use a FEES to get information to make a safe bridge feeding plan to get to the video. So those decisions go into it. But I know there's literature to support that identifying aspiration on a video versus a FEES they're pretty similar, but there are so many other things we're assessing, especially with this population.
Yeah, I think hopefully the days are over where we use video fluoroscopy just to assess aspiration. I mean, it's so much more than that. And Miranda mentioned the MBS-IMP, which is now a standardized tool, thankfully across pediatrics and adults now, which has brought huge relief to me because we used to repeat studies day in, day out because speech therapists reported them differently. But what is really interesting that even within this tool, it doesn't capture the nuances of our patients with neuromuscular disease. So for example, in this tool, we'll look at the upper esophageal sphincter opening, and the focus is always on its ability to open. And actually in a number of our patients groups, it doesn't close. So actually, you know, it's a really useful tool, but it doesn't capture the problems that some of our patient groups have. But actually this was a really useful study, and I don't think you probably can see some red marks on here. We can use video fluoroscopy for quantitative measurement. It hasn't made it into clinical practice for the obvious reasons in that, you know, AI doesn't do this for us yet. We have to hand draw, but it gives us a quantification of if we draw around the pharynx at rest and then at the height of contraction, we get a ratio. It's only 2D, that's problematic. But also you can make actual measurements, quantitative measurements of how far the US opens. So that's a useful tool. And the recent study that has shown that if speech therapists use quantification to report their video fluoroscopies, they're more likely to reveal the impairment or see the impairment compared to semi-quantitative methods, and the patient's more likely to get some treatment. But there's inherent problems, you know, it's really time consuming, so. Okay, a quick nod. I've no idea how we're doing for time. We good? I'm just going to talk a little bit about ultrasound. Again, I've been really interested in using our instrumental tools to understand pathophysiology, not just biomechanical changes in dysphagia. So again, you know, we talk about the dysphagia being underpinned by muscle wasting and atrophy in neuromuscular diseases, but we know certainly in our adult groups, but I'm sure in pediatrics as well, there's a whole bunch more where there's lots of evidence to support central nervous system deficits, certainly in some of our disease groups, but also some of our patients have things like myotonia. That's not weakness, that's muscle stiffness. So I've been really fascinated to use ultrasound as to help quantify pathophysiology and how that links with what we're seeing biomechanically on a video fluoroscopy. So, I mean, it's fairly non-invasive. It's a probe, I guess, depends where you put the probe, but if you put the probe under your chin, it's not particularly invasive. And you can get some really beautiful images of the floor of mouth muscles. So the anterior belly digastric and the geniohyoid in the middle with that beautiful rainbow arch of the mylohyoid. And that's a healthy floor of mouth muscles. And actually, if we pop the same probe onto somebody with myotonic dystrophy, I won't give you all the details of the patient, but you can see here, actually, for starters, the image is a lot grayer, which is representative of fat infiltration, and the muscles are actually also smaller as well. So you can get some really helpful pathophysiological information from muscle ultrasound, which then, you know, further down the line might be useful as a screening tool and useful to quantify response to therapy. Does what we do the drugs change the pathophysiology, or are we just changing biomechanics?
So I'm going to talk just briefly about pharyngeal high-resolution manometry, if I can pronounce it correctly. Caitlin McGrattan mentioned this a little bit yesterday. It is a fairly newer instrumental assessment that we're using. Of course, it's been used to measure esophageal dysmotility for some time, and that, of course, has its uses as well. It objectively identifies abnormalities in the pharyngeal function by quantification of pressure changes across the pharynx. There is not a ton of research for normative data, especially for pediatrics, and then clinical interpretation does require caution because, again, just like with any of these other tools, different clinicians at different institutions are rating it differently. And so we don't have a lot of consensus around that. And I actually pulled up one one research study that did show like there was high variability in the way that clinicians were interpreting this data. So it's something to consider. I think it's extremely helpful in terms of another tool that can directly give us objective information that we can use to collect normative data over time, but then also has the ability to help target specific interventions for rehabilitation. Of course, this, again, just like a FEES, does require having a probe that's passed through the nose and down into the pharynx. So comfort, hyperactive gag reflex, weak cough that might impact the patient tolerance, but overall it's tolerated pretty well and similar to FEES. I've not had the opportunity to do this personally, so I'm not going to talk too much more about it, but I am excited about it.
I have to say, someone has passed a pharyngeal high resolution manometer, well, tried to on me. And
On you?
Could not cope. Cope.
I have not had it done to myself, but I've observed it a couple times, and I feel like always on adults, and once they had it in place, they were able to handle it. But I don't know if pediatrics, that's really something that I'd have to ask our GI and motility specialists how they handle that with peds, because I don't know what it would look like.
I think the reliance often here is that the patient does have some sensory and dysphagia issues, so actually it's easier to pass and much more challenging on a healthy individual. That's what they told me when they couldn't get the probe down into my esophagus.
Okay, so we have discussed previous conferences, and again today just to highlight, like the available literature does report high instances of silent aspiration for patients with neurologic related dysphagia. We know that. Swallowing impairment frequently occurs in patients with neuromuscular disease. We also know that it is often not recognized by either the patient or by their treating physician for the same reason we just talked about. Like they come in, they say, "You having swallowing problems?" Patient says no, end of discussion. That could, like under recognition, could lead to like a reduced quality of life, increased morbidity and mortality. However, as we want to hear what our patients have to say, because when we're looking at functionally what is important to them, what is their quality of life, how is this relevant to the rest of their care, it really does take a village. It's not, are they aspirating or not? Do they have dysphagia or not? This isn't a binary decision to treat or not treat. It is a piece of their evolving care that we need to work around, and I think that's something that we all need to consider, especially in this evolving treatment era. It's an exciting time. We don't know what to expect long term. Quality of life factors need to be considered when we're determining how often to pursue, when to pursue, especially these invasive instrumental assessments.
And I think often instrumental assessment is often brandished the better assessment, and I think sometimes there's an over-reliance and over-interpretation of our instrumentation. A number of times we see video fluoroscopy reports dictating management for a patient when actually that instrumental assessment needs to be embedded into the clinical picture before any recommendations are made. Okay. We are on to the final set of outcome measures, which are performance-based outcome measures. Oh, we've got 3 minutes left. Okay, this is going to be really fast. Performance-based presentation. So just to highlight these to you, because I think they've got a real value in the place of a clinical assessment. Time-tested mastication, which is quantifiable. You can measure chewing efficiency, time it. Same way as the 6-minute mastication test, which has been designed again in the Netherlands to look at chewing fatigue. I really like the time test of water swallowing because it looks at swallowing efficiency, not just binary aspiration or no aspiration. And there's also, quantitative measures of strength that we can make. So anterior bite strength and anterior tongue strength using a bite force meter and the IOP tongue strength. But there again are inherent problems of using these in this population who have micrognathia, overbite, underbite, high palate, so the balloon will often get stuck in the palate if you don't position the balloon. So actually we have to be really careful with our protocol for these things if you want them to be repeatable and reliable. Okay, so those sorts of things are, useful adjuncts to quantifying the bedside assessment. And I think just coming back to really, we've gone through a lot of assessment tools here, but actually we really just want to know what the patients want, don't we? And we did a survey over in the UK where we got about 220 responses from adults with neuromuscular conditions and some caregivers as well. And we said, what do you want? What's important to you? And actually, and a lot of the kind of findings from that are they want early access to neuromuscular swallowing specialists. They want earlier discussion and assessment of swallowing problems. Often we're coming to this patient group too late when we're being reactive rather than proactive. Mm-hmm. And they also want some training in how to manage their own swallowing difficulties. And I think the caregiver perspective is so valuable as well, because actually our patients certainly in the adult group, sometimes don't look or present to be overly burdened by their dysphagia. But I think this quote is, really demonstrates how heartbreaking it can be for the caregivers to witness their loved ones with dysphagia and bulbar function struggle at a kind of participation level as well. Okay.
So think about what's functional. Why are we doing this? It's for the patient, right? I know we've heard from patients before that we had a patient panel yesterday who 2 out of the 3 talking to us said, I continue to do this related to eating against medical advice. And one of the things that I have found very valuable that has come out of my early access, especially to these children with spinal muscular atrophy who are pre-symptomatic and treated, is that my involvement in their care before they need me allows me to set up some very collaborative conversations with them at the onset where I say, I don't know where this is going, but this is my role in supporting you. And it's not in a moment where they are malnourished and in a crisis and they can't swallow and I'm taking things away from them, which is often how we're perceived when we're modifying a diet. It's more collaborative. It's more, what can I do to support you? How can I help you through this? How can I help you make informed decisions about your care? And that is how I ultimately look at my role in bulbar function is what's important to you? How can I help collect data on it? And how can we use that data to make your life better for you? And that does not look the same for any 2 patients. So early access, I want to just highlight that because having those conversations preemptively before the patient needs us, and this goes for things too like alternative communication devices, like we have opportunity to talk to them about what technology is available to them, voice banking their own voice into a device and things like that. And it's hard to talk about needing those things when you know you're going to need it later, but it's so valuable to do it when the patient is not in a moment of crisis. And just remembering that, it takes a village. It's a multidisciplinary thing to care for these patients. We're not assessing and treating bulbar function in a silo. We need to really take a team and patient-centered approach to this.
Yeah, I would absolutely echo that. And I think, we haven't mentioned any respiratory measures in this presentation, but measuring someone's peak cough flow in adults for us is a really integral part of our dysphagia assessment, because actually, when the bulbar system is failing from a swallow perspective, how resilient is our respiratory system to manage those symptoms of dysphagia as well? So I echo that, all of this is about a multidisciplinary assessment. But also I think for me now working across clinical and academia, I think there's so much value in us coming together to work out which outcome measures we're going to use and use them en masse and start to push forward this frontline research of real world data as well in bulbar function. So should we call it a day there?
Yeah, sounds good.
But yes, lots of questions came in. The first one, are there sensory components to bulbar function, maybe in coordinating reflexes, that could differentiate neurogenic from myogenic causes of dysphagia and comparable degrees of weakness? Do you use even crude sensory assessments to interpret results?
Again?
Repeat the question.
Sorry, are there sensory components to bulbar function?
Yeah, yes, I think we kind of touched on this. My question has always been, there is our instrumental assessments demonstrate that the person is not feeling this in their pharynx. What is the mechanism of this? And there's lots of hypothesis about actually, is this centrally mediated? And there's something else going, there's something central about this dysphagia, which I think is quite possible in some of our patient groups. Is there a visceral change that's dictating, they can't feel it, and that's not, primary neuro, it's a peripheral issue.
I think it's really, really difficult to tease out the etiology of a sensory deficit in this bulbar function. I will say the one thing that we do pretty consistently that is probably the closest thing to testing sensation is when we do a FEES, we're triggering the laryngeal adductor reflex to see if they have a cough response to that. And so that's really the only objective thing that I do that I would say is sensory testing in all of this. But yeah, it's hard to tease out what is the underlying cause.
Another question is, do we need to account for effects of possible hyperactivity on measures of scales of function, like spasms, cramps, or myotonia?
Yeah, absolutely. And I think that comes down to your nuanced assessment of knowing your patient phenotype. So, in something like myotonic dystrophy, absolutely, or cramp fasciculation syndrome, or there's lots of other factors, which is why I think I've always been quite passionate about understanding the pathophysiology and not assuming everything is down to weakness, because if we assume it's weak, we'll train it in that way and treat it in that way.
100%. The way that I'm assessing a patient with myasthenia gravis is very different than how I'm approaching a myotonic dystrophy in terms of what I am looking for in my clinical assessment.
Maybe one more, if that's okay. Are there questionnaires with elements tailored more to myotonic dystrophy and might assess use of the warm-up phenomenon to relieve tongue or pharyngeal myotonia that can initially complicate swallowing?
Great question. And the answer is, I don't think there is. Does anyone know? But we often will provide warm-up exercises and evaluate speech and swallowing pre-post warm-up, but only using the tools that we've already got. But no, I don't think so. And even in my PhD study, we've used the hand myotonia test as a kind of some sort of surrogate somewhere for myotonia, which is absolutely suboptimal, but we couldn't find any other way just to get a sense of myotonia. So if anyone has got any bright ideas on that one.
Like I do it informally, same way to you, and then just describe it in my assessment. I don't have a tool that I'm using for that.
Sorry, one more came in. For ClinRose, I don't think I heard much about surface EMG and wonder if there's any exploration of its use to better characterize bulbar function dysfunction.
Yeah, I have to say my experience of SEMG is more as a biofeedback modality for skill training, swallowing. I certainly haven't used it as an assessment for SEMG. Open to the floor if there are speeches that use it for assessment.
Okay.
No.
Thank you both so much. So we're going to take a break. We'll come back and start our multidisciplinary session at 10:15.